Here's another beautiful chart here. It delineates a lot of our insulins and the different forms and fashions of them. I will say for your NCLEX, so I still remember from 14 years ago having a question about insulin onset, time, and management. Remembering that your rapid acting has an onset of 15 minutes. That question kind of mimicked, you know, patient's meal tray arrives at XYZ time. Your insulin administration needs to coincide with their meal tray if you know you're having a patient on a rapid acting insulin, right? Because you want to make sure that you're giving the medication in the window that they'll have food to replace or to keep them from dumping, right? You don't want to give too much on that sliding scale and then they don't have a meal to come in behind it. Also knowing that, and I'll tell you, Novolog, Humalog, and Levemir and Lantus are names that I remember vividly. So remembering your long-acting, Lantus, Levemir, your rapid-acting, Novolog, Humalog. Your short-acting has those R's behind them, the regular insulin. So that peak is 30 minutes, right? That's pretty typical. If you can't remember anything else, Novolin and regular insulin, 30 minutes, 15 minutes. So that's Novolog, Humalog, 15 minutes. Study these charts, highlight it, put your note tab by it. Very important to know. Preemptively, I think I went down this list just speaking on that previous chart, but I do want to reiterate that if you're having to administer insulins and you're mixing them, always draw up your regular insulin before your NPH or your cloudy. So clear before cloudy. Say it with me at home. Can't hear you, but I trust that you're doing it. Clear before cloudy. The regular insulin is the only insulin you can give IV. Regular insulin is the only insulin you can give IV. And IV insulin is only given in ICU. All right. So when you're giving those injections, you make sure to rotate those sites. You don't want to use the same sites all the time because that will break down that tissue in that area. So always rotating. And you never aspirate or massage after a sub-Q. This is a sub-Q injection. So you'll pinch up that fatty tissue in that abdomen and inject. Even if it's a self-inject, it's a pinch, clean, inject. Do not massage or aspirate. And we talked about giving with food, being aware of signs and symptoms of low glucose, such as shaking, confusion, lethargy, and making sure to have something available if they do dump or get too low or hypoglycemic, peanut butter crackers, orange juice, anything to help recover that patient. All right, so complications of insulin therapy. We spoke of hypoglycemia, spoke of insulin resistance and lipodystrophy, and that's that breakdown of tissue underneath where you give those injections. So with the, and I'm going to mispronounce this, so I'll just, the S word here, the effect or phenomenon that occurs with that Samoji is the early morning hyperglycemia occurs due to that rebound effect from that late night hypoglycemia. So you have to kind of balance and know when to give that medication to keep the patient from feeling bad. So you can adjust the time of that insulin administration. You can lower that dose of insulin, or you can change the type of insulin altogether, but eating a snack sometimes helps with that. The dawn phenomenon is an increase in blood sugar levels between 3 to 8. And it's not brought on by nocturnal hypoglycemia. And that's to take your insulin at bedtime instead of at dinner time. That'll help that out. And eating dinner earlier in the evening. That kind of prevents that dawn phenomenon. Types of strokes. So we have ischemic. Ischemic is where the blood vessel clamps down and decreases that blood flow. If you have decreased blood flow, you're not getting oxygen to those tissues, that cellular function decreases, and now you're symptomatic. Now, hemorrhagic is where that blood vessel has a weakened blood vessel wall or aneurysm, and now it's ruptured. And now the blood is just free spewing out of that artery into the brain. So your ischemic strokes, more than 70% of them are that. A complete occlusion of the flow to the brain, because that can be from a thrombus or an emboli. So a thrombus is one that traveled to it, right? So it's blocking that blood vessel. That thrombus is sitting and occluding that blood vessel. A hemorrhagic stroke has a greater morbidity and mortality. That bleeding is just bleeding out onto that brain. You have to identify it quickly to be in order to treat it quickly. About 60% of them are the result of hypertension. So that's a high percentage. So that's why hypertension is one that we have to be very mindful of managing, so we don't overwork our cardiovascular system, and we can prevent, hopefully, that hemorrhagic stroke from occurring. So the intracerebral hemorrhage is the blood collects within the brain. A subarachnoid hemorrhage is the blood collects between the skull and the brain. So two different classifications. CT scan can diagnose either of those. And we're going to get into our good old FAST method, right? So that face drooping, this is our acronym for our stroke, which now has, I think it's BFAST now, because they've added balance onto that and other components. So the face drooping, arm weakness, patient holds their arms in front of them. Does one arm drift down, or are they able to hold them both steady? Speech difficulty. And sometimes it's not that they can't talk. Maybe they are talking, but it doesn't make any sense. And they're not putting their words together. It's like expressive aphasia. They're saying words, but nothing makes any sense. And the T is for time to call 911. Call 911 as soon as possible, as soon as you suspect the stroke.